self-efficacy. Faith, hope, spirituality, a sense of meaning in life, friends and social support, school or community support, and then the last one that you can't see up there is some socioeconomic resources. That's another protective factor. So the 5 protective factors that were talked about in strengthening families decrease likelihood of abuse and neglect or other types of things. Made very important protective factors. Resilience, the ability to bounce back after a difficult situation. Social connection, friends, community, family. Social connections are really important. Knowledge of parenting and child development. Doesn't mean you have to be an expert, but knowing what's normal at various ages so you come to expect it. That's another protective factor. Concrete support in times of need. And then social and emotional, strong social and emotional development in children, ability to interact positively, ability to communicate, ability to say how you feel. It's very important. So I'm going to say a couple of words about post-traumatic stress disorder. I'm not going to talk a lot about depression, though we've talked about it already, but we think, and we certainly learned it with our disaster work, depression goes hand in hand with post-traumatic stress disorder. And actually, people talk after disasters a lot about post-traumatic stress disorder. We found depression to be perhaps even more important in some of our data. Traumatic events subsequently learned about is a really important contributor to PTSD. So you don't necessarily have to go through it yourself, but like a violent personal attack of someone who, say, a parent, where you learn about it but you didn't witness it, a serious accident, serious injury by a significant other, or learning about the death of a significant other. So these are things, people will argue about that, but these actually are important criteria to be aware of. So you have this on your handout, so I won't necessarily go through all of the criteria, but I put them there because I think it was really important to have them up there. The criteria A, exposure to trauma and response. Criteria B, of re-experiencing. And by the way, when I started to work also with younger children, the argument was, or not when I started to work, the argument was, younger children can't re-experience. Well, that just isn't true. And there have been reassessments of PTSD or reevaluations. Michael Scaringa, Tulane's done a lot of work in that area, Charlie Zena, because young children can show through their play. Over and over and over again, they show it through their play. They show the traumatic experience, and they also get caught up in that repetition compulsion of the traumatic experience. So. And then C, the avoidance of stimuli associated with the trauma. And then D, increased arousal, and you have all that on your handout. And these are just the diagnostic, how you come up with the diagnosis. And then acute less than 3 months, chronic more than 3 months. In terms of PTSD, that's the lifetime prevalence, 1 to 14% of the general population, half recover in 3 months. Now, it's interesting, for people who are functioning reasonably well and exposed to a severe trauma like a disaster where you lose everything, you can get some of those symptoms, And actually, another interview that I did last week, people in New Orleans were having a really hard time with all the visual images of what's going on in Japan. People were very empathic, and we're all very empathic, and we're trying to do what we can to help, et cetera. But seeing those images over and over again can be re-traumatizing. Just like the 5th anniversary of Katrina, people were re-traumatized. And I'm sure it's the same thing here with with those of you who've been through the hurricanes, when you see these visualizations of the trauma. So it's just an important thing to recognize. Okay, some of the vulnerabilities that contribute to PTSD is obviously family resources, not living with a nuclear family, inadequate parenting or caregiving, family dysfunction, parental PTSD, and inability to cope with stressors. Poverty, again, isolation, and also lack of perceived social support. very important to differentiate between actual social support and perceived social support. So some people will say, oh, I've got all these people who can help me out and I'll name them. And they said, okay, if you became ill in the middle of the night and you were by yourself and you needed help, who would you call? Which one of these people would you call? And they can't come up with anybody. So there's the idea of actual support and perceived support. Okay. Now, one of the things that we need to think about in understanding trauma and understanding what goes on with children is how we assess that. And one of the unfortunate things with young children is we always have to depend on parental or caregiver report. And that's what we've got. We can't, we have to depend on that for trauma exposure, we have to depend on that for symptoms, and so that can be a problem. It's not till a child's a little bit older that we can get child report. I can tell you with our disaster work, we've done a survey in collaboration with schools, and for 4th through 12th graders, it was modified in a way that they can fill it out themselves. But for those younger, parents have to fill it out. So we really like for young children to use observations as much as we can. Tells you a lot. So, and then domains relevant to assess depending on the child's age. Attachment problems are really important for younger children, and relationship-based issues is very, very important. You can't just look at a child in isolation. I remember I finally convinced somebody that that it was important to start a program related to young children, and the person said to me, okay, we'll send you all the children, the young children. And I said, no, we actually need the caregivers too. So very, very important to recognize. So other issues. While parent report is essential for younger children, if the parent is also suffering from trauma, from post-traumatic stress symptoms, you may not get a clear picture. So that's important to recognize in terms of how you get your data. We would like to see trauma assessments included in a lot of typical intakes. We would like to see it in pediatric hospitals, in pediatric emergency rooms, because it's very, very important, because the more you know about trauma, the more effective your intervention will be. In terms of treating young children with PTSD, again, young children are very dependent on parents or caregivers, so we need to work on that relationship. Parents need to be in the treatment. We like to do treatment, relationship-based treatment. Child-parent psychotherapy is the one that we like. There's also, as I said, PCIT, parent-child interaction therapy, which a lot of people use. And then the most widely used in individual treatment is trauma-focused CBT, and there are group treatments also related to that. So those are probably the best evidence-based treatments out there. I actually should have included PCIT up there as well. All of these kinds of issues will influence treatment outcomes. We haven't talked a lot about placement disruptions, and I'm glad to do that, and the idea of wanting to have permanent placement as quickly as possible. Some of the settings for intervention, because we very much believe,
You have to sort of educate them that it's going to be a lot of loss to lose the child, but you can't lose the opportunity.
well, I think that's a really good point. I don't know if everybody could hear that, their relationship with the child is very important for the child's development, even if the child is not going to be there with them permanently. That's learning to trust and building that trusting relationship. It's interesting when you brought that up, because I worked for a number of years with some colleagues in orphanages in St. Petersburg, Russia, and one of the things that we did was work together to change the structure in the orphanage. So instead of having just changing caregivers all the time and the children moving from room to room and changing, we built in consistency of caregivers, and consistency of the children being with the same children as they moved up to another age. And the caregivers had to be there like 8 hours a day, 5 days a week. Well, exactly what you're talking about happened, that the structure originally was designed so they don't become attached. So it's not hard for them to move from group to group, the adults. And they became attached, which became more complex within the structure. So we had to help the administrators, deal with the kind of issues that they had if a child was adopted.